Professor Gortz, Professor Andre, ladies and gentlemen. It is my great pleasure to stand before you this afternoon. And since I know you slightly better, I should inflict upon you my full name. So I hope that doesn't upset you too much. So this afternoon, so once again I have to express disclosure, conflict of interest. The reason I have put the second thing is, I showed some slides in Finland last year, so I had to say that not only do I like the fallopian tube, I like Finnish people, and especially on Midsummer Night. And those gentlemen who have never been to Finland on Midsummer Night, please go solo, right? Okay. Please go solo and be very careful. The commercial interest that stopped with respect to my subject today was in 2014, because I, like other colleagues, invested in a company which provided services with MRI-guided focused ultrasound treatment, which at that time I thought was the best thing since sliced bread in the United Kingdom. I still think it is, but I sold the shares. So some learning objectives for this afternoon and for this next 16 minutes that I've listed here. And I will not test you on these unless I feel like it in 10 minutes. So we will address the role of non-surgical aspects. Medications, I'll deal with those at the end. Medication-loaded intrauterine contraceptive device. Andre, outside Ukraine, it's called Mirena. Inside Ukraine, Mirena. Mirena is Mirena. Or Spirale or something. Maybe there are other names. Then uterine artery embolization is UAE and FUS. Are they effective? Are they safe? This is what we need to know. There are not many data. Everything you want to read about it is on this slide. These are the references. So Andre, through the faculty, will make this slide available to you so you can read that. You will see at the bottom of the slide that I've referred to some personal communications with some of the pioneers of the MRI-focused ultrasound treatment in Israel. Also personal communication with Professora Leslie Reagan, the new president of the Royal College of Obstetrics and Gynecology, and also some American source. So, is uterine artery embolization practiced commonly in Ukraine? Hands up who has recommended a patient. One, yes, two, good. Okay, good. That's very good. So, as far as I'm concerned, and I'm sure those of you who use the facility, you agree that it works. Ah, silence. That means you agree. That's very good. And so how well does it work is what we may see in the publications, because the editors don't think it's new. So we don't have enough feedback on how safe or effective it is. And so I've summarized some things here. Now, the work of Hamoda is listed here, 2015. Single center study from Guy's Hospital. Guy's Hospital is how we say in Lithuanian, Švarus. Anybody speak Lithuanian here? Correct. Very good. Again, he speaks Lithuanian. He said, Švarus means clean. That means honest. Good, honest work. And so, of the hundreds of patients who went through, almost 100 patients who went through uterine artery embolization, only a quarter wished to have a baby, and there is the live birth rate. 13 out of 22 intended to conceive. Long-term follow-up. And then when one does observational studies, and one looks at the literature, and that's cited here, there are data on only just over 200 pregnancies from over 100,000 procedures. There are many reasons why these procedures are done. And what do we see? We see miscarriage rates that are up or down, caesarean section rates high. Why? It's easier for us to go and play golf or go fishing if we do caesarean section rate. There are other reasons we give to the patients, but surgical birth seems to be preferred. Not to the exclusion of safe vaginal delivery. Beware postpartum hemorrhage. So some more details on this with respect to vaginal deliveries are shown on this slide, and once again, it's in the reference from University College Hospital, from Homer and Saridogan. What was of interest to me was the prematurity rate, which is higher, but not dreadfully much higher. So again, safe enough, I would argue. But the most important thing to me when I was discussing this technology and its extended usage was because we've heard about the vasculature of the uterus and the ovary and so on. Does embolization of the vessels that feed the fibroids, does this technique interfere with vascularization of the ovary and cause reduction of ovarian fertility? You may choose the words ovarian reserve, ovarian responsiveness. I like ovarian fertility. And there are some data on this, which once again are encouraging, but it is something that must be just considered. We reproductive medicine doctors consider it. The radiologists who are the experts in doing the procedure don't understand what we're talking about. And the tests are so expensive. And so this initiative of the effect on ovarian fertility or function, the initiative must come from us. And I think that's quite important. We don't have real data. We have some observational data. The study began years ago. They're still recruiting. So the mean age of menopause for women after uterine artery embolization is slightly lower than what the students told me I taught them 20 years ago. I said 50, 51 for menopause, and the mean age is slightly lower. So we have some data which is encouraging, but as I say, watch this space. Discuss with patient. It's teamwork. It's teamwork. Joint decision making. Has anybody seen this apparatus before? I take that as a Master, you've seen this device before. Oh, what? No, it's better to put the hand down. The sign language is not international. Has anybody been in one of these machines before? Eric, for fun or for... please, no personal details, thank you. No, right. Part of an experiment, right, about ovarian fertility, yeah. So, and the principle is shown in this cartoon. So the lady lies on the exoblate machine, on the focused ultrasound device. The imaging is done, as you know, by MRI, and then the computer does the rest, but you have to have a good computer driver. Right? So the imaging doctor, an MRI specialist, and using heat, hypotense fibroids are reduced in size and lead to a reduction in symptoms. Right? Has anybody read this book? It's not written by Mikhail Bulgakov. It is written by America's Mikhail Bulgakov, John Grisham. You will find his books in the airport. And so I believe a technique has arrived and is in clinical practice and has been embraced by society when it appears in the book. Any book, look at this. he has written about MRI-focused ultrasound in this story. I haven't read the book because I don't like his books. But either in a book or if a medical advance features in a cartoon in the national newspaper or international newspaper. So we haven't yet reached this stage with MRI-focused ultrasound, but endoscopic surgeons have. Right? There have been many cartoons about endoscopic and keyhole surgeons and so on. So MRI-focused ultrasound is here to stay. And there is more information here. Perhaps we were academically more inspired because some of the questions that were asked earlier today about, okay, after the treatment, what is the time to pregnancy? It's provided here. Right? After focused ultrasound treatment, right? Then from focused ultrasound treatment to pregnancies, right? Not very long. Term pregnancies occur. Right? Then look at the age group of women who want to have access to treatment. They don't want to have an operation particularly. There are those who don't wish surgery, other women who wish to have surgery. We are all different. But these women who conceive after MRI-focused ultrasound are typically in the older age group. And focused ultrasound treatment is more effective in women in the older age group because there's less vasculature. So it's easier, not less vasculature, just less they're hypotense. And so it's easier, it's more effective. And here are the data on outcomes. So what? To the doctor, to the patient. How will I have my baby afterwards? Do I need to have a C-section? What is the birth weight and so on? Look at this encouraging birth weight. Right? Too big, maybe the mother has diabetes. Right? 3.4 kilos. Mean delivery from this small number of babies from that data. So very encouraging. So with respect to these technologies, what should we be doing? Well, we have so many options to treat fibroids in women who are subfertile, so we should prioritize. Decide with the woman and the family what it is that may be best for them at that time. It's non-surgical. Joint management, gynecologist, gynecological surgeon, fertility doctor, imaging doctor, not necessarily radiologist, MRI specialist. Right? Teamwork, or segment. Do one procedure before another, according to the woman's needs and the extent of the disease. Now, finally coming to the medications. So, the medication, and these are my last 3 slides. The medication I'm going to refer to is ulipristal acetate, commercially known as Esmia, as you know. And I was very excited when this progesterone receptor modulator hit the scene because it inspired, I use the word quite a lot, but it provoked us to think more about the endometrium and what's going on. But it's so effective with fibroids. Clearly, the multi-center study data with respect to reduction of size, reduction of symptoms with fewer side effects as a preamble to surgery, but repeated treatment may be of some benefit as well. And so I say watch this space. And the reduction in fibroid volume is shown here. It's in the publication to which I've just referred. Our old friend, which helped us shrink the fibroids, was the agonist who rendered a woman medically reversibly menopausal with all the side effects, only to have grow back later. And there are now colleagues who are questioning the usefulness. Here is an authority who comes from St. George's Hospital, Isaac Magnonda. He thinks GnRH agonists as a preamble to anything with fibroids is dreadful because it makes the surgery harder and it does this and it does that. Please read the article, make your decision about it. It was useful for us for a while. We now have better things to do. So question its place. And then Mirena. When it works, it works. When it doesn't, it doesn't. And a detailed discussion with our patient and the family doctor is always valuable, so we can individualize care. So, can infertility be improved after non-surgical treatments of this kind? I argue the case that it can. We still need to know by how much, for how many women, and the place with respect to a woman's age group and where she is in her disease. Concerning safety of uterine artery embolization, if done correctly, safe. Yes, there is a price of 2 years, earlier menopause, right? From 51 to 49. Concerning MRI-focused ultrasound treatment, safe. There may be some transient side effects associated with the procedure, but for many women that's absolutely tolerable with respect to surgery. Thank you very much.
Thank you very much. Keep us back. So, time for 2 questions. Give us very, very clear.
So, next our lecture comes from Professor Jayprakash Khan with lecture Hysteroscopic Management of Submucosal Fibroids for Infertility.
Thank you once again. It is always a challenge to follow Professor Geddes in the lecture, but I'm happy that he has set the scene for my talk, and I'm focusing on just the hysteroscopic management of fibroids. And we know that the fibroids are quite common, but obviously we want to know where exactly the fibroid is, because the implication of fibroids on fertility varies depending on size, location. So there are publications where we see fibroids as a sole cause of fertility, although it is very difficult to prove whether the fibroids is the only sort of a reason why they are subfertile. So with regard to the classification of fibroids, I'm sure you're all familiar with this classification. So generally the general classification that we use is submucous fibroid grade type 0, type 1 and type 2. Type 0 is completely within the cavity, and type 1 is more than 50% within the endometrial cavity, and the type 2 is it is bulging into the cavity but less than 50% into the cavity. And there is a systematic review where they have looked at the effect of submucous fibroid on fertility. And you can see here, although the number of studies that they have included, or in fact that are available, are very small, and it has shown that the clinical pregnancy rate is significantly lower if somebody has got a submucous fibroid. And in fact, all the reproductive outcomes are smaller. And if there is a presence of a combination, and this is another an individual study, and if there is an intramural fibroid associated with submucous fibroid, and that can also affect the fertility. What about intramural fibroid? And obviously that is, Professor Geddes was saying about the effect of treatment, and majority of them could be treated by non-medical majority of them would be intramural fibroids for treatment of non-medical management. And even if somebody has got an intramural fibroid, in this individual study, they haven't seen any difference in terms of pregnancies. However, when it is associated closely to the endometrium, so for example here, the type 3 fibroid is the one where it is intramural, but it is just touching the endometrium. And they have shown that the success rate is lower in those groups compared to type 4 and type 5 intramural fibroid that is far away from the endometrium. So it is important that, for hysteroscopic management, we need to know where exactly the fibroid is located, and that is where our ultrasound helps. So here you can see ultrasound is quite useful in terms of defining whether the fibroid is submucosal. And you can see here again, you can define whether it is a type 0, type 1 or type 2 fibroid. And sometimes we may have to use some other additional ultrasound modalities, and you can see here whether the 3D scan. So in those, you can see the endometrium is a bit ill-defined. And if you put a 3D, I'm not saying advocating 3D, but I'm just saying in certain situations, 3D might be helpful. So here the uterine cavity and this fibroid, this wasn't clear on 2D scans, but this is very clear that this fibroid is completely intrauterine or cavitary. And that is confirmed by this hysteroscopy where you can see intracavitary type 0 fibroid. And even better, we don't need 3D scans. Again, you can see here, this is very not clearly defined, the endometrial cavity. If you put just a little bit of saline, so what we use is we use an IUI catheter or an infant feed catheter, just put in and inject about 2 or 3 ml of fluid, very gently, as Kamal was saying about hycosi, having a rapport with the patient, and then see that makes the things much clearer. And again, that helps us in making a decision before subjecting them for hysteroscopy. And on some occasions, we may have to resort to MRI scan. Generally, if it's a submucous fibroid in our clinical practice, we don't routinely ask for an MRI, but just in case if we're going for a myomectomy, laparoscopic laparotomy, then that is a situation where we ask for an MRI scan. And with regard to the hysteroscopy, this is just again reiterating, we can define, and if you see on the right hand side, the top left hand one, that is a type 0, which is completely intracavitary. And this is a type 1, you can see more than 50% of fibroid is about into the cavity. The other one, type 2, is a less bulge, which is less than 50% into the cavity. So if we have a submucous fibroid, does it help in improving? We know that it has got effect on fertility, but if you're treating, does it help? And again, the evidence is not very strong, but having said that, even with a small number of studies, it has shown that if you're removing the submucous fibroid, yes, that improves the clinical pregnancy rate. And I'll go into the video again later. And as I said, again, if we know that, and we all agree that submucous fibroid treatment will improve the chance of success. And how do we, how do we plan hysteroscopic treatment? And majority of time, we use the type 0, type 1 and type 2, and there is uniform agreement that type 0 and type 1 hysteroscopic management. Type 2, it is always a little bit tricky depending on the size and things, and this group has come up with a plan or a prediction of how successful the hysteroscopic treatment will be. And this is step W classification, so it's basically that the size of the fibroid, topography, where exactly it is located in terms of the position, and extension of its base, less than 1/3, 1/3 to 2/3, or more than 2/3, and how much is the penetration into the myometria, into the cavity, into the myometria. And they have added lateral wall as well. So they have graded into 0 to 2, and 0 is less risky, and in fact it will predict that complete removal possible, whereas a 2 is more difficult. And they've added 1 point for if it's on the lateral wall. And you can see here they have done their own internal validation, and it was externally validated as well. And 0 to 4, low complexity hysteroscopic myomectomy. If it is 5 to 6, it is a group 2. It is a high complexity. You might consider something, as Professor Gary said, about giving GnRH or smear, or consider 2-step hysteroscopic myomectomy. And with the other one, we have to consider other alternatives. That's what they've come up with. So, what are the indications? So, as I said to you, that's type 0, type 1, uniform agreement. Type 2, depending on the size of fibroid, and in case if it is too big, then we may have to even consider, if we are proceeding with a myomectomy, we may have to consider laparoscopic or laparotomy myomectomy. We do have to consider a 2-stage procedure, Generally, one thing that we'll have to be aware of that is how much is a myometrial margin beyond the fibroid if you're doing a submucous fibroid, especially if it is penetrating. The preoperative assessment, we have to clearly predict what the pathology is, making sure it is not anything nasty, have to take an informed consent and appropriate instrument as well. We don't routinely do any ambulatory hysteroscopy, but there are a number of units, I'm sure, in Belgium might be doing an ambulatory myomectomy, and generally the consensus is if it is smaller fibroid. And with regard to the consents, as a routine infection, bleeding, injury to the cervix, injury to the uterus, fluid overload, and also we have to warn them about incomplete procedure, adhesions, and in fact, although we are doing this in a fertility patient, because of the adhesions, that can cause a bit of long-term effect. Operative plans. Ideally, we want to have a thin endometrium, so early follicular phase, but not practically possible, especially in our practice in the NHS, depending on when the slot is available. So for that reason, we always give a single shot of GnRH agonist in the cycle prior to when they are having treatment. Or we could give Esmia, ulipristal, for about whatever, 1 month or 2 to 3 months. I would rather say if it is Esmia, it might be best to use a little bit longer. We need to dilate the cervix, and that is one procedure where we can injure the cervix or a false passage, and therefore I do routinely give the misoprostol. Generally, the publication is basically you give the misoprostol orally or vaginally the day before. Due to practical difficulties, we do tend to give on the day about 2 to 3 hours before the procedure vaginally, so we put in the list and we keep her as a second or third case. And that helps in terms of improving the cervical, making the things easier for dilatation. We have different modalities, monopolar or bipolar receptoscope or a mechanical. We do give antibiotic because that is one aspect, at least in our mind feel that that reduces the chance of infection, therefore reducing the risk of adhesions. Hyaluronidase gel anti-adhesions, this is not a routine practice that we do, especially if it's only a single myoma when we are resecting. If it is large, we have to consider a two-stage procedure and a follow-up hysteroscopy planning. It's not routinely done in our practice, but that is something if you're doing more than multiple myomectomies at the same time, or if it's a large myoma, that may be considered. Intraoperatively, we have to always have a good vision, and we need to know where exactly the fibroid is attached to. So we have to move our hand, move the hysteroscopy, and changing the pressure, intrauterine pressure, so increasing or decreasing, because sometimes we may have to decrease as well, because it might be, reducing the pressure possibly helps in terms of when to stop or whether she's bleeding heavily and things. Removing clots, removing any sort of debris or tissues which is probably blocking the scope. We have to look at the fluid balance. So for that reason, if we have available any irrigation systems, it is best to use it. And just prepare, just in case if she bleeds heavily, having a Foley's catheter for an intrauterine pressure, or tranexamic acid is a good one, just to give 1 gram of tranexamic acid IV, and obviously if there is a complications with laparoscopy is readily available. Now, intraoperatively, as I said to you, electrosurgical, that is monopolar or bipolar. So we could use a sort of electrosurgical slicing, and one aspect with the fibroid is always towards us, not away from us, because towards us is more safe. So you go beyond the cervix, beyond the fibroid, and then pull it towards you. That we are certain that we are not doing any sort of a damage. Then the systematic way. You start with at the top and then gradually come down. So in a systematic way and towards the base as well. And when do we stop? We stop at the endometrial surface. It is best not to dig in too much because potentially that increases the risk of having injury and perforation. And another thing is just in case if you can't do it completely, probably it is best that we have to do it in a two-stage procedure. What about the mechanical one? The mechanical one, the advantage with that is obviously it is a blade, there is no sort of a diathermy involved, so the endometrial damage is minimal. We always worry about whether it bleeds. Generally it doesn't bleed, And that is where the intrauterine pressure helps, because with the increase in pressure, that stops the bleeding at that time. But after the procedure, usually the uterus contracts and the bleeding stops. And if we need to, we can give a massage, uterine massage, or some other procedures like giving tranexamic acid, etc. And one major advantage with this is because we are not, there are no chips with the electrosurgical slicing. With the bipolar, there will be chips and we need to remove those things. Whereas this one, there is a suction which is attached to it, and that gives a good view throughout the time, and that's single insertion. So, how does it matter? With the monopolar resection, we have to use a hypertonic, so the glycine. We have to use, with the bipolar, we can use an isotonic distension media, and obviously there's a long learning curve for both the procedures. Whereas a mechanical, I'm not sure whether you're familiarized with the mechanical one, which is quite easy to do. The learning curve is shorter because we can actually look at and see and treat. So it's basically the machine does most of the stuff. And with regard to the fluid overload, as I said to you, we need to be cautious about how much fluid overload, and there is an ESGE guidance just recently published, and they have reiterated that if it's a hypertonic solution, it is 1000 ml, so we have to keep in how much is going in and how much is coming out. And 750 ml, if somebody who is at risk of fluid overload, like renal problems or cardiac problems, then keep it up to 750 ml. With the normal saline, isotonic, we still have to be careful, and the cutoff is about 2.5 liters. And if somebody who is at risk of having a fluid overload, it is 1500 ml. And we all know that if the size of a fibroid is bigger, it takes a longer time. So it's always best to keep the time as low as possible. I mean, because then the risk of procedure-related risks are much lower. And the chances of completion, depending on, again, the type 0, type 1, and type 2. So we have to be bear that in mind in terms of counseling patients before proceeding with the procedures. And with regard to the discharging instructions, we have to warn them that there could be discharge, initially possibly a serous discharge or a bloody discharge for about 1 to 3 weeks. There can be crampy pain 1 or 2 days. And obviously we have to advise them that if there is a fever or any signs of infection, they have to come back because there is a possibility of some complications. And it's generally advised avoiding intercourse, that is again to reduce the risk of infection for a week or so. And if it is needed, if there are more than 2 fibroids, if it is a little bit complicated, we always do it in a 2-stage procedure, especially if it's an anterior and posterior, because once we do it, it can stick together, the adhesion formation is more. So if you are doing those kind of situations, then yes, it is best to have a follow-up hysteroscopy in about 4 to 6 weeks' time. And the outcome in fertility population, if you're giving submucous fibroid, there is a nice review paper which is published in 2016, and they have actually looked at, in fact, they have tabulated all the studies which have been published, and the pregnancy rate in those women have, this is all natural conception, so that has certainly improved. A couple of things that they've noted is there's a higher cesarean section rate, and they have queried about the risk of uterine rupture, but obviously the prevalence of uterine rupture is extremely small, as we always take precautions and things. So to conclude, I've shown you that submucous fibroid certainly affects the fertility, and surgery for the submucous fibroid confers a benefit. And we have to do a good preoperative evaluation to look at the size, location, and number of fibroids. And we have to consider giving GnRH or smear to reduce the size of fibroid, and that makes things easier. But even otherwise, the GnRH agonist in the endometrium, and that improves the visualization of fibroid, and precisely we can do the resection. We may have to consider 2-stage procedure, especially if fibroid is larger, and it certainly gives us a good clinical outcome with minimal complications. Thank you.
Thank you so much. Шановні колеги, у кого є питання? Одне, ладно, не два, одне, хтось, один. Втомились після ланчу. Yeah, thank you so much. Yeah, I thought about it.
Yeah, same question. Have you ever perforated the uterus? Good question, eh?
How many times? Second question from me.
If I say no, you probably will think that it is a lie.
No.
I haven't. I haven't. But having said that, something that we have to take into consideration, and that is what we always discuss in our meeting, is we take hysteroscopy as a very light procedure. Like, somebody who's coming with a menorrhagia or a small polyp, we always do the hysteroscopy. And in those situations, we had a patient who was about a year ago. She was 26. She had a hysteroscopy, basically that there was a tiny polyp, and she had a life-changing event. It was a life-changing event. It was perforated, done by one of our junior trainee, and she had to have a resection of the bowel. And then during the bowel resection and bowel repair, she had to have the bladder injured, the bladder was stuck, so she had to have 2 laparotomies.
Thank you. Do you think there is a place for simultaneous ultrasound, transrectal or transabdominal when doing these procedures? Yes or no, don't know.
I think there is a role, but not as a routine. Yeah. If there is a difficulty in cervical dilatation, we have used it under ultrasound guidance, like we do the embryo transfer.
But not the cervix, the fundus is what I'm worried about.
I haven't tried. I think
We are always using ultrasound in the operating room when we are doing operative hysteroscopies. It's always there. Certainly if you have an intramural one, where you're going till 5 millimeters from the parametrial thickness left over, we always have the ultrasound in. But I have another question. Going back to the shaver, or mechanical one, so in our experience, this shaver can be used best for polyps. Myoma is a little bit more difficult, but it's always, myomas are completely into the cavity. If you go intramurally, then the shaver is becoming very, very difficult then.
Dictionary microphone.
So next speaker again, Dr. Kamarocha, who will give us some more information. As you know, the ESC and the HV set up a new classification system on congenital uterine anomalies by the Konuta group. And so I'm very pleased that I have not to keep correct, but Kamal is going to do it. So please, Kamal.
Thank you once again, and post-lunch sessions are always very heavy. Not only on the stomach, but also on the eyes. I have terrible problems. Luckily I'm sitting in the front row, so you can't see me. But you can't sleep now. Because this is important. I think the classification for uterine malformations has changed. As a student, when we were a medical student, we always like to look at the classification, and we used to get a sheet of paper and used to write down what was seen in the laparoscopy and how we classify. So now, looking back after about 20 years, the classification has been looked at and has been changed. So we're going to go through this today, and then we'll see, Jay will talk about how we can manage them afterwards. So 2 things here: the prevalence, the classification, the diagnosis, 3D ultrasound, and summary. So prevalence, there are many, many papers, and therefore everybody says something different. Somebody says it's 1 to 10% in unselected, say 2 to 8% in subfertility, and 5 to 30%. There was a review article where they looked at about almost 89,000 patients, and they found in the unselected group it was 5%, 5.5%. In the infertile couple, it was 8%. Where there was a miscarriage or recurrent miscarriage, it went to 13.3%. But it was mixed with infertility and miscarriage, then it was 1 in 4, 24.5%. So you see, if you see a patient who's had recurrent miscarriage and is having fertility problems, then really you must look for some malformation. And what are the things you look for? Of course, if you look at the incidence in early pregnancy loss, you can see that it's a very small group which has got malformations. There was this word called arcuate. It is gone in the archive now. and it's changed. And as I'll show you as we speak, how it has changed. So arcuate was confusing, and we'll talk about it a little later. But you can see a small group that was having some malformations. Going back to the fetal growth, 6 weeks undifferentiated, 9 weeks differentiation has taken place, around 12 to 14 weeks the formation has taken place, then the resorption of the septum is taking place, around about 19 to 20 weeks is complete, and the vagina is also open excepting for the hardening that is there. So you can see by 20 weeks we have moved on to a complete normal structure. So what could happen? If there's failure of development, then you will lead to aplasia, complete absence. If partial or half developed, then it's unicornate uterus. If you look at the fusion defects, if you have got a horizontal defect, then you're looking at bicornate uterus or the diadelphus, as we said in the past. If you're looking at fusion defects which are septal, which is vertical, then you're looking at vaginal septum. And of course, if the septal resorption hasn't taken place, then you get partial or full septum. So you can quickly see how the effect is on the type of malformation. So this is the one that I used as a student long time back, and it is now changed to the new classification, that is S-ray ESG. For those who haven't seen, this is the classification to follow actually. It's got the uterus as the U from 0 to 6. Then it's got the cervix from 0 to 4, and the vagina from 0 to 4. So you have U, C, and V, the 3 parts of it. And then if you go further to the uterus that we're trying to talk about today, you have the normal uterus, you have the dysmorphic uterus, which has got T-shaped or infantile type of uterus. Then the septate is partial or complete, and then you've got a bicorporeal, which has got partial or complete and with septate. And that is, you see, is slightly different compared to what we have seen before. Then you've got the hemiuterus, with or without a rudimentary cavity. And you've got the aplastic, with or without a rudimentary cavity. So you can see quickly how the whole picture has changed here. You add on to the cervix, add on to the vagina, your classification becomes complete. Of course, you know, this particular classification has got additional now varieties to put under, that 39 types. And we'll go on to the diagnosis. So you can look at the history, examination, which may give you some information, and then the different modalities of investigation, like hysterosalpingogram, ultrasound, 2D, 3D, sonohysterography, MRI, hysteroscopy, laparoscopy, and hysteroscopy alone. So there are different ways you can do things. And you can see on the side there, 3D is already showing off that I'm the best. Get it? Are you awake? So, it's nice to get everybody involved in the program. Hysterosalpingogram, I was doing that earlier. The hysterosalpingogram you can see here, bicornate or bicorporeal, and then unicornate. You can see again the septate, and you can see some hydrosalpinges in the HSG picture. Look at MRI here now. You can see the septum, you can see the bicornate, and then you can again see the partial septum. Moving on, this will be touched by my next speaker, but you can see quickly in a bird's eye view the normal cavity, the septum with the hysteroscopy, unicornate, and then the bicornate varieties. And this is your normal 2D scan. So you're scanning, as I said, when you scan, you're going to scan the whole uterus. And so you're going into one end, you finish the uterus, then another cavity comes up. Then you come back and you see the cavity. So you can see one cavity transversely, keep going, suddenly you see 2 cavities on 2 sides. So 2D examination is so useful. This is 3D now, what you're doing. So you can see now the capture is taking place. It takes about 5 or 10 seconds to get a picture. And when you're doing 3D, you don't move your hands, so the machine does everything for you. And here you're calculating the 3D image, and you get your 3D. The coronal picture is the bottom left one. And it so easily picks up any deformity that is there. So, moving on to doing the 2D for something called a septum, you will see that in the septum, the two cavities are very close to each other on the ultrasound. So if you're doing a 2D examination, you've got two cavities that are very, very close, most likely this is a septum. If it's far off, then most likely it's bicorporeal. So you see here, you can see the cavities are too close to each other, and then the 3D picture shows you the septum on the side. So you do not need to have the 3D machine with you. You can do things with the 2D itself. Here again, you can see the top left picture, which is the longitudinal view. You can see if you stay in one place, you're going to miss this picture. As you move to transverse, you're more likely to get the two cavities close to each other. And then your 3D view gives you the two subsubtate uterus. And it's so nicely delineated here on the 3D. Again, if you put some saline into it, you can see the septum hanging, and you can see on the transverse view and longitudinal view, as well as in the 3D view. So sonohysterography also is a very useful method to assist you. If you don't have a 3D machine, you can quickly make out that the septum is there in between. But 3D, of course, it makes it much more simple and easy. So here you can see again the classification, reminding you the changes that have taken place. And if you look at the next picture, this is the old slide, which showed us the normal cavity, the arcuate, then the bicorporeal, the septum partial, and the unicornate. And then the new one we created when the new classification came out. And you can see how the T-shaped and infantile uterus is there, septate, and again the unicornate uterus. So, further, just a closer view of the same pictures you can see again, and the three types on the top and the three at the bottom. And if you look at the rudimentary horn here, there you can see the unicornate uterus one side. And when I'm teaching students and they come to our workshop, we say if you see a unicornate uterus, then look at the side and make sure that you check that properly, because the small attachment will show a rudimentary horn. And that is very important information, because if that rudimentary horn has got a cavity or is communicating, then there could be a pregnancy coming there, and that could be dangerous. So don't just finish there, just keep scanning till you see the small little part of the uterus. This is very typically seen here, so you can see the picture quite clearly with some blood circulation around it. Again, what is it that you're looking at on the picture, on the image? So you see the side pictures and the 3D pictures, and this fundus is got nice and smooth, and that's in the normal cavity and as well as in the septum. Whereas in the second image, you can see the fundus is dipping in. These two things are you going to look at, and that you can make out with 3D. So you got the interosseous line between the two ostia, and that part is coming down where the fundus is normal. Whereas in the second image, you can see that the fundus is dipped, and the interosseous line is still the same. So you can see two important things that you need to remember when you do the 3D scan in delineating your type of abnormality. So you can see here nicely. And again, one of the criticisms of this particular classification is the thickness of the myometrium. It should be 50% less dipping in, as well as in the anterior and posterior. And that aspect has been criticized by this particular paper, saying that you see in this image, although it's 50% less, but still one is a normal cavity and one has got a partial septum. So it is an area where probably this classification may be refined in the future. So look at the accuracy, diagnostic accuracy. You can see 3D ultrasound is clearly on the top, very closely sonohysterographic. Then comes the HSG, and 2D ultrasound is close on the heel to HSG, and then you got the MRI. So the MRI, somebody was asking me yesterday, the use in fetal scans in malformations is no longer done in our hospitals. And somebody asked about fibroids and MRI, and that will be 14 weeks onwards. In our unit we do MRI scans because ultrasound doesn't map it properly. The mapping is so important for treatment. So the failures of ultrasound. So patients could present with amenorrhea for complete agenesis. They could be asymptomatic in the other group, with cyclical pain, sometimes with a pelvic mass, sometimes a urinary retention. I think this slide is going to tell you the whole story where we want to know about conception, miscarriage, preterm labor, and malpresentation. So if you see the conception rate, the only thing that's affected is in septate uterus or subseptate. Otherwise, it's decreased as well as normal. Miscarriage is in the septate as well as in the bicorporeal or biconjugate uterus. Otherwise, the uniconjugate uterus is also included in the first trimester of miscarriage. The second trimester, you can see, is increase in the septate. We're calling it arcuate silk because this is an older paper. And then you've got increase in the biconjugate uterus. And preterm labor, you can see, is increase in all. Malpresentation is in all. So you can see how the association in uterine malformations could be picked up. The birth weight, we talked about birth weight earlier, about other factors like fibroids and treatment. Here you can see that the birth weight is affected with uterine malformations. And you can see the various causes or possible associations, the reason why this adverse outcome could be taking place. So, let's sum up. 2D scan and HSG are good screening tools. If you got that machine, use it. Because you can pick up and say, this patient needs 3D scan. If you have the 3D scan, then use it. And learning is very easy. It's just like 2D, excepting a few things. It is really proven to be diagnostic for uterine malformations and classification. Of course, you'll get cases where it will be difficult, and you'll need to use other modalities, and that's the complex, the suspected dilemmas, where you do MRI, laparoscopy, hysteroscopy, as well as 3D ultrasound. I'm happy to take questions. I've kept it brief and precise. Thank you.
Thank you very much, Kamal. So, some questions?
Kamal, would you do a cerclage for a pregnant woman with afterbirth? Would you do a cerclage to, in view of premature delivery rate in all the types of uterine anomalies?
Circular.
Sure.
Yeah, I know, I understand.
What's your outcome?
Yeah. I will let the next speaker say that. But no, answer is no. Treatment is coming up. You guys have understood, it's very clear. Thank you.
So, thank you, Kamal, very much for a very interesting and extremely scientific lecture. And now, I hope we will hear even more interesting lecture. Not to compare interest, both of them interest, but more practically oriented. Because now Dr. Jayaprakash will tell us what to do with all those pathology so clear described by Kamal, Ashraf, and Desgit. So we trust you. You will tell us what to do.
Thank you. Thank you once again. I think, you know, we are having possibly a bit of overlapping with regard to this, but I'll skip most of the slides because I didn't see what Kamal was preparing. So the outline, basically the diagnosis, which Kamal has already covered, the reproductive implications I'll briefly touch upon, and then the clinical management, and then finally the conclusion. And I just wanted to take you through this slide, just to reiterating again the diagnosis. So basically, as Kamal said, in a hysteroscopy, if you are seeing a normal internal contour, which is reassuring, and a normal external contour, which is reassuring. So the combination of laparoscopy and hysteroscopy is a gold standard. And that is very important before we are starting the management. And if you're seeing this, I mean, there is a possibility, but we all have been doing hysteroscopy, so most of us probably will agree that it is likely to be a septate uterus. But having said that, when we are seeing something like this, we have to look at the external contour. So for example, at laparoscopy, if you are seeing this, and a combination of these two will confirm it is a septate uterus. However, if you're doing a laparoscopy and if you're seeing this, and if it's a combination of this, it is a biconate, or in fact bicorporeal based on the new classification. And you can imagine if you're thinking that this is a septate uterus, and if this is the combination, and if you're going and operating, perforation. So that is why I just wanted to reiterate this again. Okay, I think we have covered all this. Okay, so now with regard to the management, majority of time we will conservatively manage. We don't do anything about it. And we probably, if I ask you, many of you will say, no, we can just leave it alone. And many of us, we will say, yes, we have to get on and a bit more proactive with regard to the surgery and things, if you're incidentally seeing it. But having said that, if somebody who is coming with a recurrent miscarriage, and if we have investigated for all the relevant investigations, and if you find it is unexplained recurrent miscarriage, then yes, I think we probably agree that yes, this is the only thing that we have found, then it is best to resect it. But the question is if it is an incidental finding, and I'm not going to answer that, but maybe I can answer later on. And how do we do the metroplasty? And it's mainly that we look at the septate uterus, and how do we do the metroplasty? Obviously, the hysteroscopy has made the things much easier, and previously, many of us used to do it under laparoscopic guidance or ultrasound guidance. Now the 3D ultrasound has made it completely different, because that is the gold standard in making a diagnosis, because we can see the external contour quite clearly and the internal contour quite clearly, like a combination of laparoscopy and hysteroscopy. And one additional thing, and this is a routine practice that we do, basically that you draw a line, the interosteal line. So where you see the ostia, the tubal ostium which comes and joins, you draw a line and then you measure the septal length. So that will give us an idea about what is the septal length and how far that we have to go. And when we are using a scissors, and it is generally about 6 millimeter and it is magnified, so you can have a bit of guidance about that. Or if you're using a Versa point, again that tip is about 6 millimeter. So you can have a guide about how much is the sort of thing that we have to go for. And various, sorry, it's all going all together, but various instruments that we have, it's a 0-degree loop. And that is what we used to do in the past when we didn't have any scissors or these kind of instruments available. Or you can use a needle diathermy or just a cold scissors. And the cold scissors is probably helpful because it's less likely to have any damage to the endometrium. But I'm sure most of us, when we're doing the procedure, and if the septum is quite thick, it is not easy to do with that scissors. And therefore, majority of time, we use the needle diathermy. Or even if you have the Versa point, which is a bipolar needle, usually it is straight, and you can actually bend it a little bit with an angle, and you can use that. And it is in fact even more safer. You don't have to dilate the cervix more than 5 millimeter, and as well as you can use just the saline. And as I said to you, this is 3D ultrasound quite helpful, and this lady unfortunately had a myoma as well, a fibroid as well in one of those things. And when I was presenting this at a meeting, one of the leading UK experts has said that he wouldn't do it simultaneously, both together. And I completely agree with him with regard to this, that because if you're doing a combination of procedures, there is an increased risk of having adhesions. And therefore, he said he probably would do that in a 2-stage procedure. And it is best to be done in the early follicular phase, or after having a single shot of GnRH injection, as I said about submucous fibroid management. What about post-operatively? What would we do? And it is a routine practice that we do give, although there is no convincing evidence, that we do give estrogen, estradiol valerate, as we give in a frozen embryo replacement cycle. 2 milligram, estradiol valproate, 2 milligram 3 times a day for about 6 weeks, and in the last 7 to 10 days we add progesterone. With an aim of improving the endometrial development, and that hopefully will act as a sort of a barrier in terms of reducing the risk of adhesions. And it is a routine that we use an IUCD, so it's a copper device, so that is basically keeping in between two endometrial surfaces and therefore reducing the adhesion. There are some balloon stents as well, which is a triangle shape, and you can insert the balloon stent and inflate, and that again keeps the endometrial surface, the two endometrial surfaces separate. And we do give an antibiotic that again to reduce the risk of infection, because that could be the reason for adhesion. And a hyalo barrier, which is not routinely done in our unit, but hyalo barrier has been suggested, so that reduces the risk of adhesions. And we invariably do a check hysteroscopy, especially that as we are doing an IUCD following the procedure, estrogen for about 6 weeks, and after that, when they have had a period, then they come back and having a check hysteroscopy, removing the coil, making sure that there isn't anything, and it is done usually as an outpatient procedure, the check hysteroscopy. And even if there are some adhesions, it's usually tend to be very, very minimal, and you can actually divide that safely with the cold scissors at that point. But does it make any difference? And there are some evidence, and this is a paper which is a systematic review published a long time ago in 2000, Fertility Sterility. And what they have looked at is those who have had miscarriages before, and then the people themselves acted as a control. So they had the septal division, and then how that improved. And then the miscarriage, the outcome has improved. But this is not a nice sort of studies, because patients themselves are acting their own control. And for any surgical study, this is not a good sort of a study, because invariably the outcome is going to get better, because they are acting themselves as a control. So we should ideally have people who have got a uterine anomaly, they have been treated or not treated, and then looking at the outcome. And this nice systematic review has shown that there is no evidence that improves the chance of pregnancy. So for the fertility reasons, subfertility reasons, it might not be beneficial. But in miscarriage, that significantly reduces the chance of miscarriage. So it actually reduces the chance of miscarriage in recurrent miscarriage population by about around 2/3. And there is another paper which has been published. Should we do septal division for all of them? And this nice study, a cohort study, where they looked at people with a recurrent miscarriage or people with no poor reproductive outcomes. So that's an incidental finding. And what they have shown is that the benefit is much better if there is a poor reproductive history in the past. Whereas if it's an incidental finding, it hasn't made any huge difference, although there has been a trend. What does our Cochrane say? The Cochrane has looked at a randomized control trial, and there's no randomized control trial, and they said if it's an incidental finding or a recurrent miscarriage, it is best to be done as a research trial. And the same group has set up a trial in 2008 with the aim of completing in about 2 years. They still haven't finished recruiting. They have just only halfway through. And the problem is many of the specialists and patients are not willing to take part. If there is a septum found with a recurrent miscarriage or fertility, either the patient says, I want a septal division, and the doctor says, yes, you need a septal division. And therefore, it is extremely difficult to recruit into this surgical trial. NICE, as you know, it is in the UK, they give the recommendations, and what they have come up with, and this is a good backup support for clinicians, where they have said if somebody who has got a recurrent miscarriage, there is evidence based on not the randomized control trials, other cohort studies, evidence that it improves the miscarriage, it improves the reproductive outcome, and therefore those who are experienced with a multidisciplinary team, making sure that the diagnosis is absolutely certain, then you can go ahead, and we need to review the practices. And what about fertility population? If somebody who has got infertility, and then if you are seeing a septum, they have said evidence is not absolutely clear, but having said that, they are not prohibiting us that not to do. What they said is you could still do it in a way, but we have to be clinical risk management, everything, all the system should be in place. So that means a multidisciplinary team, and we need to audit our own practices, making sure that the risks are not increased. So that is about septum. I just wanted to go through with a couple of slides for dysmorphic uterus, which Kamal has alluded to, like a T-shaped uterus or a tubular uterus. This is not a routine practice that we do in the UK, but there's been a lot of interest in Europe. where you can see this is a T-shaped uterus, and obviously the diagnosis is, see the interosteal distance, that is wider, whereas at the isthmus it is much narrower, and that probably reduces the size, the uterine cavity volume, and potentially improve the chances of miscarriages. And what they said is they come up with, a technique where you make incision, so an incision on the side, lateral wall to expand on either side, and also an incision from the fundus up to the isthmus in the anterior wall and the posterior wall to improve the ovarian, the uterine volume, as I showed you here. So that is what they have seen, that the uterine volume has significantly improved, and that is measured. And again, they have shown that the outcome, the live birth rate, has significantly improved. But here again, the patient themselves has acted as control. So it is not a control with the patients who have got a T-shaped uterus and not treated. And there is a recent paper which is published just recently from China, and they have looked at the unique ornate uterus, and this is the one that Kamal has shown, that unique ornate uterus also has got increased risk of having miscarriage. And many of us will say, no, you just have to get on with it, and hopefully they will have a normal outcome. What they have said is possibly you can increase the volume of the uterine cavity, where you make a cut from the fundus about 1 centimeter or 2, and then going down up to the isthmus on the opposite side of the tube, so that the volume again is increased. And they have shown again that the outcome has improved, but again the patient themselves have had a fertility problem, and then they had the surgery, and obviously the outcome is better. I'm not going into detail about this, sorry, it's a bit complicated, but that is again after the procedure. So to conclude, uterine anomalies, we have shown that it is common, it associates with adverse reproductive outcome, and the septal division reduces the miscarriage rate and live birth rate. However, the evidence is not based on the randomized controlled trial, and there is a randomized controlled trial which is on its way. And for other abnormalities, hysteroscopic treatment, non-septal abnormalities, there is limited evidence. Thank you very much. And before stopping, I just wanted to the question Martha has asked about whether cervical cerclage will help. Sorry, I wasn't preparing for that, so I don't have that slide with me. But there is one study which was published in American Journal in 2005. They followed up uterine abnormalities, and then they measured the cervical length, and then they followed them up for preterm deliveries. So obviously the cervical length, if it is less than 2.5 centimeter, they classified as high risk for preterm labor. And the one group that they have shown that the highest at risk for lower, shorter cervical length and higher risk of preterm delivery is a unique ornate uterus. With the septate uterus, there is no reduction in cervical shortening, or there is no reduction in preterm delivery. So one group, if you are considering, then the unique ornate uterus is the one where they need to have a cervical length, and that is what we follow in our practice. Thank you.
Thank you, Jay. Шановні колеги, питання є чудово. Questions coming.
Маленьке питання. Чи користуєтесь гелями?
Sorry, just one minute.
Після вісцерорестектоскопії, ну, наприклад, після видалення перитинок, чи користуєтесь антиспековими гелями? Застосовуєте?
We don't use anti-adhesion gel. I don't have much experience with this, but it is generally, if gel is available, you just put it in, and I'm sure Stefano will give us.
Yeah, well, we are using it on a systematic basis certainly in congenital uterine anomalies. We are always injecting the allobarrier gel. There are some data, because the allobarrier gel stays in for 72 hours, okay? And so there are some data in literature, although not convincing, but that the postoperative adhesion formation rate is lower when using a gel than when you're not using it. It's not randomized study. Well, it's randomized, but it's not well performed yet.
Добрый день.
Ваши рекомендации по поводу планирования беременности после реконструктивных операций ветропластики при маточных перегородках и ветропластики весовых утерус. Через сколько разрешать планировать беременность? Последующие роды.
I don't think there is any sort of a convincing data, but in our practice, what we do is, as I said, we give the estrogen for about 6 weeks, progesterone, and then have a bleed, and then we do a check hysteroscopy in removing the coil, and then we'll ask them to have one more period, and then start trying. And with regard to the cervical scanning, I do generally, if somebody was a recurrent miscarriage, I generally ask for a scanning at around 12 to 14 weeks for the cervical length. Generally because, it is a sort of a precious pregnancy. I mean, I know it is not a term that we can use, but generally that I do, if there is a septal division done, I always ask for a cervical length. That wouldn't add too much of work to the department, which I checked with our team. So.
Well, and one question will come from me, if possible. Do you have, maybe you met in literature, or maybe you have your own statistic, any risk of abnormal invasive placenta after endoscopic treatment, hysteroscopic treatment of ovarian anomalies? Any statistic? Because of destroying basement brain? Yeah.
I'm not aware of any statistics, but I have read in review articles, with regard to the potential risk of placental adhesion, placenta previa, and even placenta accreta, depending on the extent of the surgery. And we never have any experience. But again, because it is not that prevalent, but I'm sure our master, Stefano, do you have?
I don't know. So the only thing we have seen is that in the group of patients with T uterus which have been treated, that in this group we have, I think, 2 or 3 patients with placenta accreta. So we will see, but if it's really due to that, no.
So please, Jay, when you come back to London, meet Professor Chandraharan, because he strongly believes that any hysteroscopic invasion will increase risk of abnormal invasive placenta.
No.
He told me every day about that when I visited London. Thank you so much. No?
Thank you very much. Okay. So then we are moving back from the uterus to the tubes. Again, Antoine Waterloo will tell us about the place of salpingectomy in the prevention of ovarian cancer.
Okay, so we move again to the tube to ask this question. Is it necessary to remove tubes to prevent ovarian carcinoma? I have to say that I will give you some cue, but we have no complete evidence as today, and then we may discuss that if you wish. First of all, I have no discovery of interest in this subject. And so I think we have briefly to see these 4 chapters. First of all, the facts from tube to ovary. Then we have that the clinical attitude, the technique, and the limit of that. First of all, the fact from the tube to ovary. Concerning ovarian tumors, we have the ovarian tumors of low grade. They are approximately 10% of the ovarian tumors, and then we have the high grade, which represents 90% of the ovarian tumors. And that it is the worst tumor, that it is what we are today considering, because maybe we have some evidence that the tube may lead to this kind of tumors. So the question is the relationship between the ovarian serous carcinoma and the tubal lesions. So is the ovarian carcinoma originated from the tube? We have to say that 50%, 55% of ovarian carcinoma are epithelial tumors, and most of them, 54% of these, are serous. The serous carcinoma, in fact, the cells are very close to those of the tubal epithelium, and when you have a high-grade serous ovarian cancer, very frequently, 3 out of 5, you can see that we have a molecular p53 mutation. And we will see during this presentation that the p53 mutation is probably a leading factor to this kind of anomaly. And this carcinoma which is more frequent in the BRCA mutation patient. And it is from this work that it was first said that maybe we have some relationship between the tubes and the ovary concerning the ovarian cancer. And it was first seen when we apply a protocol which is a C-film, sectioning and extensively examining the fibroidal end during salpingectomy. And this protocol, which is a cytopathological protocol, has been systematically made in patients with BRCA having an annexectomy, because as you know, we propose to do annexectomy in this patient when there is this kind of mutation due to the high risk of ovarian cancer. And then, if you look very closely to the tube, you will see a lot of patients with lesions we are calling stick serous tubal intraepithelial carcinoma, with very intense expression of this protein, p53. And what is also very important, that most of the lesions are mostly located to the fibroidal end of the tube. So it was the first fact to say probably there is a relationship, and as you know, the fibroidal end is very close also to the ovary, which is probably also an important factor. This paper, which is, I think, quite important, a meta-analysis about patients with the BRCA mutation, about 341 patients, where this patient has prophylactic annexectomy. They found in this patient almost 4% of serous carcinoma. But when the SIM protocol was applied, it means the extensive observation of the tube plus ovary, 17% of serous carcinoma has been discovered, and in which 57% also have stick, because this lesion which is a precursor of the tubal cancer. And these lesions were always found in the fibroidal end, once again. So you see the things seems to be quite consistent with this publication. And we have some others. I don't want to put all this publication on the screen. So now we have to try to find the theory, or to find the logic in that, and there is different theories. We have to say that today, no theory is absolutely perfect. The first one was by Chen in 2010, who says that, we have probably 3 steps. First of all, the first one is when there is a signature of p53, which lead to tubal intraepithelial lesion in transition, and then to the stick, which is a serous tubal intraepithelial lesions. And when you see, which is probably interesting, the DNA alterations, you see that the alteration starts from the step 1, as soon as you have the expression of the p53, and then, of course, it goes until we go to the nuclear cell atypia in the step 3, where we have already the stick. But it is one of the theory. Another one, which is also consistent, quite close, says that we have the low-grade serous carcinoma, and from the tubal epithelium, you can go to the low-grade serous carcinoma, and it is exactly the same for the high-grade, but there is one difference. It is once again the p53. It means when we have, is on the right of the screen, when you have a low-grade carcinoma, if we have a mutation of the p53, then you have a high-grade carcinoma. But also this mutation can occur very, very early in the tubal epithelium, so you directly go to the high-grade carcinoma. So have the 2 possibilities of carcinogenesis. And once again, we have, the fact that the fibroid is very close to the ovary, so the stick, you can imagine that there is a migration from these cells to the ovarian surface. last possibilities and last theory, which is probably one of the best, I don't know, is to say that we may have, the benign tubal secretory cells. We go directly to the ovary, which is common, and do what we call endosalpingiosis. And if you have this mutation P53, then we have directly a serous carcinoma. That phenomenon could be directly in the tube. So from this cell, we have the P53 signatures, then the stick, and then the serous carcinoma. But from the stick, you can go directly to a metastatic serous carcinoma, which means that you may have already metastatic carcinoma, it has been seen, metastatic serous carcinoma in the ovary, but in the tube, you will only find the stick. So it's an important theory because people did not understood why we sometimes see serous carcinoma in the ovary and only stick in the tube. And that could explain that. And that it is the other way to go to the cis adenocarcinoma, which is a purely ovarian process. So that these theories, probably they are close to the reality, we are not sure, but maybe the last one is the best one. So, if we accept that, what do we have to do as a clinical attitude? First of all, we have to say that there is some risk factor to have this kind of serous tubal carcinoma. The risk factor is the tubal inflammation, and the chronic salpingitis is probably one of the factors. Inflammation and menstrual reflux induce liberation of cytokines, interleukin-8, TNF-alpha, which may damage the DNA and lead to the stick. So any aggression to the tubes may lead to have a stick, and of course chronic salpingitis is one of the factors. And on the contrary, we may think that there is some effect of the pregnancy and the pill contraceptive. So when to do a salpingectomy, what we can propose? First of all, in case of hysterectomy, under the age of 50, I think that today we are allowed to propose a systematic salpingectomy in this patient. And that it is once again the interest of laparoscopic approach versus the vaginal approach, because as you know, it is quite easy to do, very easy in fact, to do salpingectomy during hysterectomy by laparoscopy. When you do that by vaginal route, sometimes it is not so easy. Indeed, after the age of 50, the classical attitude to make the annexectomy remains, what we have to do. Now, in case of sterilization, what we have to do? Only salpingectomy, only if Essure is not available, because you know that Essure is now quite popular. Patient over 40, and of course, after information and consent, you cannot remove the tubes without explaining everything to the patient, and to explain why we are going to propose maybe a little more, I will say, invasive operation. So, obviously, in case of sterilization, salpingectomy cannot be recommended on a, I will say, systematic way. Now, the technique in case of salpingectomy, we already speak about that this morning. It is important to stay as close as possible of the tube, because even if you know this patient, if you do hysterectomy, will not have some kids in the future, but we have to respect the ovarian function, and so it is important to stay very close to the tube. And what it is probably the most important things is to remove all the femoral end, which is not sometimes very easy to do, because as you know, there is ovarian fringe, which is very close to the ovary, and it is through this fringe that we may have the propagation of the tubal cells to the ovary. So if you want to make a proper job, really you need to remove all the fibria, including this fringe which is there, which is very close to the ovary. If you don't do that, you may think that there is probably no impact of your salpingectomy. Now, the limit of this attitude in case of salpingectomy, it is in BRCA patients. It could be very good if we may say to this patient, instead of annexectomy, we are going to just remove the tubes. But today we have no sufficient evidence to propose only a salpingectomy instead of annexectomy. maybe through the tubal biopsy that was proposed by Stefan this morning, which is a very elegant way to do it. Maybe if you say we have some evidence of stick, it could be a good argument to do that. But once again, today, if you have a patient with a BRCA mutations, the logical and I would say official attitude is to propose the adnexectomy, not only the self-injectomy, because we are not sure that it is sufficient to do that. So to conclude, I will say that we have more and more evidence of relationship between the stick and the serous ovarian cancer, and we may make some prevention. I think today the most prevention we can do is when we do hysterectomy. Of course, we don't do hysterectomy for that purposes. But if you do an hysterectomy, I think that the recommendation today is to do self-injectomy. I think that we already agree. And the real impact, in fact, will take time to be proven because, it's not so evident to have, I would say, all the statistical evidence to say that it is a good attitude. Thank you very much.
Thank you very much. So, time for some questions.
Is everybody agree to remove the tube during an hysterectomy? Yes. If somebody does not agree?
What to do if these young patients, 26 years, who still like to have children with BRCA1 or 2, is positive with familial history? What do you suggest to these patients?
Today the classical attitude is to propose adnexectomy. Propose an adnexectomy, it means to remove the ovary.
But even when she has got no children?
No. After the children, no. The attitude today is to say, do the kids you want as soon as possible. After that, it's another story. But we don't think that it is logical to propose the adnexectomy so young and without the kids. But as soon as the kids are done, yeah.
Yes.
Thank you. Do you know, are there any connection with stick and borderline tumors of ovary? Are there any connection in the literature maybe, or stick and borderline tumors of the ovary?
Apparently, no. Until today, what it is said, it is the stick directly linked to ovarian carcinoma, and probably it is due to the mutation, the P53 mutation, which means that directly we can go from the stick to an invasive carcinoma. And we have today, I've not seen any papers. Maybe there is some. Maybe it will come. And up to today, I've not seen publication about borderline tumor. No.
Ще питання? Просто наступного разу, щоб задати питання доктору Ватерлоу, доведеться їхати в Ліон. А він найкраще все ж таки в світі фахівець стосовно хірургії маткових труб. Немає ніяких контроверсій. Він просто питав, чи всі ви погоджуєтесь з тим, що якщо робиться гістеректомія, то обов'язково видаляти труби.
Thank you for interesting presentation. And one question: if you informate the patient that it is necessary to remove the tube, all the patients agree with you in this situation. If you informate the patient that you must remove the tube, all the patients with you agree with you in this situation.
During an hysterectomy?
Yes.
Yes, because it is quite easy to explain that if you remove the uterus, we have no interest to keep the tubes. So,
but without hysterectomy, maybe no.
No, I don't propose self-injectomy when there is no other hysterectomy. I think today is the point.
A lot of questions.
For hydrosalpines, if somebody who has got hydrosalpines pre-IVF, we always advise self-injectomy to improve the chances of success. And some people use clip application. Some people use e-shore. So in those situations, do you think that we should propose salpingectomy, bilateral salpingectomy, if it is a bilateral hydrosalpinx, as the first approach to extend because of this reason as well?
I see. In fact, I will propose salpingectomy instead of e-shore or clip for, I will say, obstetrical reason more than due to prevent the ovarian cancer. Because as you know, we have some concern about the use of e-shore instead of salpingectomy in case of hydrosalpinx, and the same for the clip, because we may have a very, very big hydrosalpinx above the clip. So, except if it is very dangerous, I think that the reasonable attitude is to remove the tubes. And in fact, we may say also that to prevent the ovarian cancer, but there is no clear, it is not very clear, because when the tube is blocked, probably it prevents the ovarian cancer as well, because we have no real connection between the tubal mucosa and the ovary. And as you have seen, these tubal lesions come from the tubal mucosa, so probably there is no impact, but we don't know that it is purely theoretical. So I remove the tubes, but not for this reason.
And concerning Assure, there are beautiful data recently published that if you use Assure before IVF to block the tubes, that results, the pregnancy rate is lower after Assure than after salpingectomy.
Yes, absolutely, yes.
With ectopic, we are doing salpingectomy more and more. One tube is gone, the other tube is there. Maybe in the future we'll have data that the ovarian cancer started in one side, because one tube is gone in the other. So interesting area for research for somebody.
I see the silent question in the eyes of Professor Grudzinskas. And of course you'd like to address that question to you. But I'm ready to answer him, because his question, when it's time for coffee break. I respond you, now. That's all, sit down.
I haven't finished talking.